everyone, we are now going to talk about a very important part of pediatric examination, and that's the approach to a child with cyanotic heart disease. So it's important for you to know how to recognize someone with a cyanotic heart disease, because a cyanotic heart disease is sort of like the equivalent of I don't know, maybe a myocardial infarction in adults, in the sense that it is a dire emergency. Now, there are very few cyanotic heart diseases which are not emergencies. So, it's important for us to recognize when to suspect that someone has a cyanotic heart disease, and remember, most of these are very time bound, and that's the important part of today's class. So, we'll start off with a case. So, 3-day-old baby of Nina, so it's a 3-day-old baby of Nina, is brought to the emergency room with history of fast breathing with noisiness and irritability. Now, you get some history. So, it's a term normal delivery. Birth weight was 3 kilograms. The baby cried soon after birth. There was no respiratory distress soon after birth, and there was no jaundice. The baby passed urine and meconium within 24 hours. And basically, because it was a normal delivery, it's a normal weight baby, they were discharged at around 24 hours after birth. So, this baby has now come to you on day 3. So, this baby has just got discharged probably the previous day, and this baby is now brought to you with fast breathing and noisiness and irritability. Now, on examination, what do you find? You find that the baby is irritable, is not feeding. The mouth and the extremities are cyanosed. There is no pallor, there is no jaundice. The heart rate is 180 per minute, so the baby is tachycardic. The baby is tachypneic as well, so there is a respiratory rate of 72 per minute. The weight is now 2.8 kgs. So, all of you should know that a normal newborn can lose up to 10% of birth weight in the first 10 days and then regain it over that period of time. So, we are not so worried about this weight at this point of time. On examinations, you do quick examinations, you do not have time to do a detailed examination right now. The baby is cyanosed. So, the first and second heart sounds are normal. There is a short systolic murmur heard. On the respiratory system, you have bilateral normal breath sounds, but you have crepitations heard everywhere. And you have a liver which is palpable 5 centimeters below the right costal margin. So, let us analyze this case. Now, you have a 3-day-old baby who has presented to you with respiratory distress, cyanosis, tachypnea and tachycardia, with bilateral crepitations and hepatomegaly. Your CBS system examination is not all that very remarkable. There is just some short systolic murmur. It is not helping you much, isn't it? So, when you put these all together, what do you have? So, you have a baby. So, you have got tachypnea, tachycardia, bilateral crepitations and hepatomegaly. So, automatically you know that this child is in congestive cardiac failure. Now, this child with congestive cardiac failure has a respiratory distress and cyanosis. So, the first thing that we do is we are going to check the saturation of this baby. So, the SpO2 of this baby. Now, when we check the SpO2 of this baby, we get a saturation of say 68%. Okay. Now, your normal saturation has to be more than 94%. Now, you get a saturation of 68%. Now, this is really scary. What are you going to do? You are going to start this child on oxygen, right? So, you start oxygen by mask or by nasal prong. Now, once you start oxygen by mask and nasal prongs, what we are next going to do is we are going to wait to see if the saturation improves. Now, you started oxygen. Now, you decide to give this child 100% oxygen. Okay. So, suppose you have a blender and you have a really good system to fit it. Okay. But otherwise, the easiest thing to do is attach something called a non-rebreathing mask, and you give this child something called 100% oxygen. So, you now look for improvement in saturation with 100% oxygen, and the maximum the saturation climbs to is 74%. Okay. So, what did we just do? So, what we did was we found a child with central cyanosis, we found a neonate with central cyanosis with CCF with a saturation of 68% in room air, and we gave them 100% oxygen. So, it is a cyanotic infant with low saturation, you give them 100% oxygen. Now, ideally, when we give them 100% oxygen, what we are supposed to do is we are supposed to measure the partial pressure of oxygen. So, you do a blood gas, an arterial blood gas. So, you do an ABG and you look for partial pressure of oxygen, and what you want when you give them 100% oxygen is you want the PaO2 to climb to more than 150. Now, what have I described here? So, basically we gave 100% oxygen to a cyanotic infant, we did an arterial blood gas and we are looking for a partial pressure of oxygen on the arterial blood gas of more than 150. So, this whole thing together is called the Hyperoxia test. This is very important because this is the most important thing which is now going to distinguish whether your cyanosis and your respiratory distress are cardiac or respiratory. Okay? So, we did a hyperoxia test. Once you did a hyperoxia test, in this particular infant you found that your partial pressure of oxygen was only around 65. Okay? So, no matter what you are doing, despite the fact that you are administering 100% oxygen, partial pressure of oxygen in this child does not climb to more than 65 millimeters of mercury. So, how do you report a hyperoxia test? You either report it as passed or failed. So, if you pass the hyperoxia test, it means it is a respiratory problem. So, that means your partial pressure of oxygen went up to more than 150, and if you fail the hyperoxia test, it means it's usually cardiac. So, our baby is a cyanotic infant with a low SpO2 for whom we did a hyperoxia test, and what did the baby do? The baby failed the hyperoxia test. So, it's going to be a congenital cyanotic heart disease. Now, this is the important thing that you've got to see. So, what's our diagnosis? It's a congenital cyanotic heart disease. Now, what are the important things we need to know about? The important things that we are going to look at here are, why is this heart the way it is? Why has this baby presented to us at the time that the baby has come to us? And what are the factors which could possibly influence this? So, you have a CCHD, now you need to decide what sort of CCHD it is. So, how are we going to decide that? So, for that we need to know the anatomy of the heart. Now, all of us know, so now I'm just going to draw a very simple line diagram to say how the heart is and how blood is going to flow. So, now this is the 4-chamber diagram of the heart that all of you have to have by heart, pun intended. So, you have the RA, and the RA drains into the RV, you have the LA which drains into the LV, you have the vena cava which drain into the RA, and you have the pulmonary veins which drain into the LA. Now, all of you know this. So, the vena cava bring back oxygenated blood. So, the superior vena cava from the superior portions of the body, inferior vena cava from the inferior portions of the body, they bring back deoxygenated blood into the right atrium. And I am going to mark this with blue arrows. So, you have deoxygenated blood coming from the vena cava to the right atrium, going into the right ventricle, which then goes into the pulmonary artery. From the pulmonary artery, it goes into the lungs, and from the lungs you have oxygenated blood, which I am going to designate in red. You have oxygenated blood which comes into the pulmonary veins. Through the pulmonary veins it reaches the left atrium. From the left atrium it goes into the left ventricle. From the left ventricle it goes into the aorta to the rest of the body, and from the rest of the body it comes back as deoxygenated blood. So, the body extracts the oxygen that it needs and comes back into the vena cava, right. So, this is the circuit, and as you can see it's in series, right. So, if I am going to draw a diagram, another diagram to tell you how this goes. So, basically you have blood from the vena cava going into the RA, which go into the RV, which go into the lungs. So, it's the pulmonary arteries which go into the lungs, which then go into the pulmonary veins, which then go into the LA, then to the LV, then to the aorta, and from the aorta it goes back to the vena cava. So, this is a series circulation, right. So, this circulation is in series. This is a very important thing to remember, right. So, it has to happen sequentially, has to happen one after the other. It's only if this happens in this particular way that things are going to work out properly. Now, Why should a child develop cyanosis? So a child should develop cyanosis either if there is a block in the pathway to the lungs, right? So what are the possible blocks that can happen to the pathway? So you can have a block at the level of where the right atrium enters the right ventricle. So you could have you have the tricuspid valve there. If there's something abnormal with that valve, you can have a block. If there is something abnormal with the right ventricular outflow tract, so that's the right ventricle to the pulmonary artery. So if you have a block there as well, you can have a problem. Now remember, if you should have a problem, you should have some way to decompress these things. So cyanotic heart disease is only going to happen if there is mixing of blood somewhere and this deoxygenated blood can reach the rest of the body. So that means that it's not just enough for you to have a block, you should also have a way for it to go and mix with the oxygenated blood and reach the rest of the body. So if you have a tricuspid problem, or if you have a pulmonary problem, or if you have a right ventricular problem, any of these, so basically you have some kind of an obstructive right heart lesion, right? So obstructive right heart lesions. So what are the obstructive right heart lesions that we can talk about? So these obstructive right heart lesions are, so I said you can have a problem at the level of the tricuspid valve, so you could have a tricuspid atresia. You could have a block at the level of the pulmonary vessel, so it could be a pulmonary stenosis, it could be a pulmonary atresia, so any of these things. So yeah, either it's not developed at all or it's that it's very stenotic. Now you could have a combination where your tricuspid valve is slightly abnormal and your right ventricle is not developed very well. So there is something called the atrialization of the ventricle. So your tricuspid valve, instead of being where it is, it sort of moves down. So I'll just show you that in black. So suppose your tricuspid valve is somewhere here. So what happens? You don't have much of an RV at all, isn't it? And your RA is now unnecessarily large and it doesn't function very well and the tricuspid valve is abnormal. We call this particular thing something called Ebstein's anomaly. So what all did we have? So we had tricuspid atresia. You can have an anomalous valve which has led to a really abnormal right atrium and right ventricle, which we call Ebstein's anomaly. You can have an abnormality of the pulmonary artery and the pulmonary circulation itself. So you could have a pulmonary stenosis or a pulmonary atresia. Now suppose all of this occurs together. So you have a tricuspid atresia, you have a pulmonary atresia, you have a right ventricle which is not well developed. You can have something which we call hypoplastic right heart syndrome. So HRHS. So basically the right side of the heart is not properly developed at all. So blood cannot reach the lungs, thereby it cannot get oxygenated and thereby you have cyanosis. So basically you have obstructive right heart lesions which prevent blood from getting oxygenated. This has to move to the left side. So usually you have an associated ASD, a very large ASD in cases of tricuspid atresia and Ebstein's anomaly, or you can have a large VSD as we see with pulmonary stenosis and pulmonary atretic conditions. So these are one set of lesions. So that means that there is no blood flow going to the lungs and all this happens, right? So this is one set. Next is you could have something which causes something wrong with that series circulation which we were talking about. Now what happens if your pulmonary artery, due to some poor fate, your pulmonary artery develops from the aorta and the aorta develops from the right atrium, from the right ventricle. So basically you have a switch of these great arteries or a transposition of great arteries. So what happens in transposition of great arteries? So you remember that circulation I was talking to you about earlier. So your vena cava drain into your right atrium, which drain into the right ventricle. Now if you have a transposition of great arteries or a TGA, your right ventricle then pumps out into the aorta. What does the aorta do? It goes to the body, brings blood back to the vena cava. Where are the lungs? Lungs are totally bypassed by this particular circulation. Now you have the other side, isn't it? So you have the pulmonary veins which are draining the lungs. So, your pulmonary veins drain the lungs. That goes to the LA, that goes to the LV, that goes to the pulmonary artery now. So, it is a TGA. So, it goes to the pulmonary artery, which goes to the lungs, and it goes back to the pulmonary veins. So, what happens? You have two circulations which should have been happening in series. Instead of that, you have two parallel circulations. So, you have two parallel circulations which are happening in transposition of great arteries, and unless and until you have some kind of way to connect these two circulations, this child is going to die, right. So, what are the connections you can have? So, unless there is an ASD, a very large ASD, or there is a very large VSD, or there is a very large PDA between the pulmonary artery and the aorta, unless there is some way to connect these two systems, they have to run in series. Unless there is a way to connect these systems, these are not there, it means that this child is going to die. So, transposition of great arteries is one of the most dramatic conditions which can present to you as a congenital heart disease, and it's a dire medical and surgical emergency. It has to be corrected immediately, right. So, this is a transposition of great arteries. Now, what other condition can present to you as a cyanotic heart disease? Now, we said transposition of great arteries. Now, when I say transposition of great arteries, I am going to go into the developmental embryology of the heart, and that's the development of the truncus arteriosus. So, the truncus arteriosus is the outlet system of the heart. Now, this truncus arteriosus has a septum in between it, and this septum has to spirally rotate inside, dividing the truncus into the pulmonary artery and the aorta. Now, if the septum does not rotate, or if the septum is absent, you can have problems. If the septum rotates abnormally, you can have a pulmonary artery which arises from the aorta, from the left ventricle, and you can have an aorta which arises from the right ventricle. So, basically it is an abnormality of how the arteries are committed to the ventricle. So, this is the term cardiologists use. An artery needs to be committed to a certain ventricle. Now, if that does not happen, you can have an abnormality. Now, what if the septum did not form at all? So, if the septum never formed, you end up with one common chamber which arises from the right ventricle and the left ventricle, and blood from both of these will pump out. Part of it will go to the lungs, part of it will go to the rest of the body, and this anomaly is what we call a truncus arteriosus, right. So, where did we find anomalies? We can either have anomalies with the right side of the heart, which is supposed to deal with the deoxygenated blood. So, you could have anomalies on the right side of the heart where there are obstructive lesions, or you could have problems with the vasculature and where they go. So, the problems with the vasculature could be that they are arising from the wrong ventricles, or they are committed to the wrong ventricles, which we call transposition of great arteries, or you could have a primitive artery, which is the truncus arteriosus, which never divided at all, or has divided at all the wrong places, such that you have mixing of blood happening. You have a structure called the truncus arteriosus. Now, this is just an approach class, and I don't think that at the undergraduate level you should have that much of in-depth knowledge. It's a nice to know thing, but it's definitely not a must know thing. It's important that you know how we broadly classify these, and that's what I'm going to come to next. So, basically these are the ways in which you can have abnormalities. You can have abnormalities to the right side of the heart, you can have abnormalities in the vessels. But remember, any cyanotic heart disease, if life needs to be sustained by a cyanotic heart disease, there needs to be a connection, there needs to be a mixing somewhere. So, either you should have a shunt at some level, it has to be an ASD or a VSD or a PDA, something like this, which helps this deoxygenated blood get to the lungs, get oxygenated, and then get to the rest of the body. So, this kind of a mixing, at least, it's not that it has to be perfect, there has to be some mixing for that child to survive, right. So, this is extremely important. We will talk about this more in clinical features. So, how are we going to classify this? So, when I said that there are problems which cause obstruction at the right heart level, it means that there is no blood flowing to the lungs. So, we call these, so if you have a child with CCHD, we are broadly going to first divide them into, so those in whom blood is not reaching the lungs. So, those are decreased pulmonary blood flow. okay. And the other side in which we found that the arteries are abnormal, so the aorta was going to the lungs, there was a large common chamber which was going to the lungs. And I forgot one more aspect in the last slide, and the other way that you can have deoxygenated blood trying to reach the rest of the body is if your pulmonary veins, so again it's a problem of vessels, if your pulmonary veins don't drain into your left side of the heart and they decide to drain into the right side of the heart. So you have 4 pulmonary veins, any of these pulmonary veins can drain into the wrong side of the heart. But if more than 3 drain into the wrong side of the heart, then you have virtually no oxygenated blood reaching your left side. So all of these pulmonary veins go and drain over here, and this is called total. So in total, ideally you should have all 4 pulmonary veins draining into the right side of the heart, but at least 3 is what's important. So total anomalous pulmonary venous return or connections. So we abbreviate this. So cyanotic heart disease is full of abbreviations. I'm very sorry for that. So if you abbreviate this, you get either TAPVR or what we commonly call TAPVC, right? So you have pulmonary veins going into the right side of the heart. So again, you have no oxygenated blood reaching the rest of your body. So again, here as well, you need to have some kind of a connection for this child to live. Otherwise, this child is going to present with deep cyanosis and cannot make it. So we had situations where, so I'm coming back to this again, sorry to take you back and forth a little bit, but you've got to remember there were situations in which no blood flow was reaching the heart. There are situations in which increased blood flow reaches the lungs. So you have situations of decreased pulmonary blood flow and increased pulmonary blood flow. Now let's just go and see diagrams and see how this is going to happen. So we'll first talk about increased pulmonary blood flow, mainly because there are very few of them. So the first of these is that you have a switching of your arteries. So what happens here? So I'm just going to mark this for you in black because it may be easier for us to see. So basically your aorta is going to drain, your left ventricle drains into your pulmonary artery and your right ventricle drains into the aorta. So you have the PGA, and this is the prototype of increased pulmonary blood flow. So just picture this, your LV now drains all of the blood that's coming from the lungs and goes straight back into the lungs. So LV drains into pulmonary artery and LV drains into pulmonary artery and RV drains into aorta. So this is the TGA. The second most important system is there is no septum between both of these vessels. So we end up with a situation where there is no septum over here. This just becomes one big common chamber, and that's the truncus arteriosus. And the third one is where I said that all of your blood goes from the left side of the heart to the right side of the heart. So basically, instead of your pulmonary veins draining over here, the pulmonary veins drain over here. So your right side of the heart now has a large amount of blood because your venous return is coming to the pulmonary venous return is coming back to the right atrium. From the right atrium, it goes into the right ventricle, from the right ventricle into the pulmonary blood flow. So, you have got a large blood flow reaching the pulmonary circulation again. So, this is TAPVC. So, these are your prototype increased blood flow conditions, right? Increased blood flow conditions. In addition to this, I will just put one more disorder which is again a nice to know thing rather than a must know thing, and that's something called a double outlet right ventricle. So basically what the right ventricle does is it sort of pumps to both RV as well as it pumps into both the pulmonary artery as well as the aorta, and basically because of that it ends up having a large strain on it, and over time it leads to issues with that. So it's an increased pulmonary blood flow setting, so you can have a double outlet right ventricle, but this I would say is not a very important thing at all. So as far as you guys are concerned, you need to know the TGA, you need to know the truncus, and you need to know the TAPVC. So these are your classic increased pulmonary blood flow settings. Now what about decreased pulmonary blood flow settings? Now decreased pulmonary blood flow settings, we said they were obstructions. So if you have an obstruction here at the level of the tricuspid valve, you have tricuspid atresia. If this valve descends further down and instead of having a valve over here, you have a totally abnormal right ventricle and right atrium. So, this is something which is called Ebstein's anomaly. And finally, if you have an obstruction at the level of the pulmonary artery and blood cannot go into the pulmonary artery, it could be because of a pulmonary atresia or the classic disorder. I am sure all of you have been thinking, why is she just not talking about this particular condition? It's the condition that we know of. That's the Tetralogy of Fallot or TOF. So, one thing that most of you should have noticed if you were paying attention is that it's all T's, right? So, almost all of the cyanotic heart diseases somehow, I don't know why, they all start with T, and this becomes a very easy way for you to remember what the cyanotic heart diseases are. So, if I am just going to go back to this particular slide, I will just put them all here. So, if you have an increased pulmonary blood flow, it's a tricuspid atresia, it's a TOF, and in increased pulmonary blood flow, we had PGA, we had truncus arteriosus, and we had TAPVC. So, these are the big 5 T's of cyanotic heart disease. If you can name and sort of draw these, you're basically sorted, you're basically done. So, this is I think the most important 5 diseases that we classify under cyanotic heart disease. To this we can add diseases like Ebstein. So, I will put this in another color, then it sort of becomes a little easier for us to remember. So, you could have Ebstein, you could have pure pulmonary atresia with some kind of a communication. So, you could have a pulmonary atresia there, and so that's about it. And you can have a DORV, as I said earlier. So, you can have a DORV with pulmonary stenosis when it will behave like a decreased pulmonary blood flow, or you could have a DORV without pulmonary stenosis, in which case it could behave like an increased pulmonary blood flow setting. So, basically I would suggest that you remember these 5 big T's of cyanotic heart disease. So, the T's of cyanotic heart disease, right. So, this is I think a very easy way to remember cyanotic heart disease. So, for a very long time when anybody asked me, I could just name these and I couldn't name any other cyanotic heart diseases. So, what are the clinical features? So, now they will commonly all have cyanosis, and this cyanosis, remember, in little babies, unless they are absolutely blue, and I mean like actually blue, the cyanosis can be very subtle. So, it is very similar in color to the color of the ink that I am using right now. So, if you see this kind of a tongue color, this kind of a color in the nail beds instead of a bright pink, then you need to suspect that this child may have a cyanotic heart disease, which is well mixing. It is only if they have no blood flow going into the heart that they end up in a situation where they have a blue color, a really blue color. Now, so most of the time their cyanosis can be slightly subtle, so you have to diagnose it using a saturation. So, you must take saturation in at least 2 places, and that is the right upper limb and the right lower limb. The reason we take the upper limb and the lower limb is the presence of something called the PDA. So, you have the patent ductus arteriosus, which can shunt blood. So, ideally in the fetal period, it used to shunt blood from the pulmonary artery to the pulmonary artery to the aorta, because you had the sinus venosus and you had the vessels coming from the umbilicus, you had the blood shunting past the lungs. So, basically whatever blood flow came into the pulmonary artery had to get shunted into the aorta. So, that was fetal circulation. So, because you have the PDA, and this PDA can be present in the first 3 days of life as well, you could have shunting happening across. So, it is important for you to check saturation in the right upper limb as well as the right lower limb. If both are less than 94% despite administration of 100% oxygen, so you do the hyperoxia test and then you prove that there is cyanosis, right. So, there is central cyanosis. So basically this is what you primarily do, your preliminary examination is this much. So as far as you guys are concerned in a clinical examination finding, so cyanosis is your first clue. Next thing is the age of presentation. Now the most important factor which determines when the child presents is the degree of shunting or the degree of mixing. So suppose you have good mixing. So when we were talking about this particular line diagram, I'm just going to go back to this again. So suppose you have good mixing happening between these. So that means you have a very large ASD, or you have a very large VSD, or you have a very large PDA. So if you do not have these connections, the first point at which these kids will manifest to you is when the PDA closes. So when does the PDA close? So the PDA closes, the first stimulus for the PDA to close is the first breath of the baby. So the baby is exposed to very low oxygen tension inside the body, inside the uterus. So when the baby is in utero, the oxygen tension is somewhere around 35 millimeters of mercury. Right? So this is what happens in fetal circulation. Now when the baby comes out, suddenly this baby is exposed to a partial pressure of oxygen which is more than 60. So when this PaO2 ex utero goes to more than 60, that becomes, so this hyperoxia is the first stimulus for the closure of the PDA. Now this is just a constriction so that the flow across the PDA sort of reduces. So the aorta is not going to shunt blood into the PDA because it's now sort of functionally closed, but this PDA begins to physically close by day 3. Right? So initially there is a functional closure, and this functional closure will occur by 3 days. So it's around 72 hours of life, and this is a very, very important number for us to remember. This PDA will completely close, I mean anatomically close between 2 weeks and 4 weeks of life. It can go up to 6 weeks, but anatomically that closure, this fibrosis and closure of that PDA will happen by at least a month of age. But this functional closure usually will happen by 3 days. And this 3 days becomes a very significant thing as far as age of presentation goes. So any of the lesions which we were talking about, especially these obstructive lesions as well as PGA, if the PDA begins to close by day 3, they will usually present to you by day 3. The exception to this is TOF. So usually the age of presentations when these children crash and present to you is usually 3 days of life, and that's around the time that the PDA begins to close. Now there are different ages of presentation which you may have to know. It's there in many books, but I would suggest that you remember that the ones which are really critical. So these critical lesions I am talking about are the TGA. The next one is the truncus arteriosus. TAPVC, sometimes Ebstein. So if you don't have a good enough connection between a good enough shunt happening anywhere, these lesions can present to you by day 3 of life when the PDA starts to close, because there is no shunt, there is no way for blood to mix between these two sides. There is absolutely no way any kind of series circulation can occur. So one is that. Second thing is something like a TOF. A TOF usually has mixing happening unless the pulmonary stenosis is so critical. So unless there is a critical pulmonary stenosis or a pulmonary atresia in a child with TOF, that child is usually going to present to you later. They can present to you from 3 days to any point of time. Now suppose you have a decent enough shunt happening between all these things, the age of presentation is going to become slightly later. But invariably they will usually present to you within the first 6 weeks of life, and this is a very crucial time because the earlier you can detect these lesions, the better your outcome is going to be. So as far as you guys are concerned, you need to know that you can have increased pulmonary blood flow and decreased pulmonary blood flow settings. The age of presentation is something which is very important. Many of these lesions may present to you by day 3 of life. We are going to put a name for this, and that's called a duct dependent circulation. Now all of these things have implications for us as far as management goes. So you can have a duct dependent circulation, and this duct dependent circulation is what's going to present to you by these 3 days of life. Now I want you to remember these terms, it's very important for you to do that. Okay. So now suppose it's not a duct dependent circulation, it can present to you slightly later. Now TOF presents to you in quite a classic way, and we are going to discuss TOF in a lot of detail, because as far as you guys are concerned at the MBBS level, TOF is one thing you have to know. So here we are just going to talk about the other disorders, the most important of which is a TGA. Now TGA is the prototype disorder we are going to talk about. Now if TGA does not have a connection, it will present to you by day 3. If TGA has a good connection, has a good mixing happening between the right and left side, it becomes an increased blood flow setting. So what do they present to you with? They present to you with congestive cardiac failure. Okay. So they are going to present with features of CCF. So they will have tachycardia, they will have tachypnea, they will have hepatomegaly. In addition, they will have a central cyanosis which does not improve with oxygen. So they are going to present you with CCF. And remember, when we talked about ACHD, acyanotic heart disease, we said that CCF will usually present when the pulmonary vascular resistance starts to drop and there can be flow into the lungs. In this case, the pulmonary vascular resistance need not drop. So they can present you much earlier with CCF, but the CCF will get more pronounced as the pulmonary vascular resistance drops. So this is an important thing you've got to remember. They can present you with congestive cardiac failure and they will have cyanosis. Right? Now this is almost uniform for most of these disorders. So be it truncus, be it TAPVC, be it TGA, all of them will present you in a similar manner with features of CCF and cyanosis. So it's important for us to make this distinction over here. Now what are you going to get on examination? Unfortunately, so early, so that means within that early infancy, early neonatal period, you're going to hardly get any kind of sounds that we hear about. So we always talk about hearing a pansystolic murmur for a VSD, hearing a continuous murmur for a PDA. Unfortunately, as far as cyanotic heart diseases go, they can be quite subtle. So you usually, if you're, most of the time your mitral valve is normal. There's one exception which we'll talk about a little later. So for most part, S1 tends to be normal. S2, depending on the pulmonary valve, it may or may not be abnormal. So you may or may not, so it could be normal, it could be split, widely split, because you may have increased blood flow going through the pulmonary artery, so it becomes widely split, or it could become single. So you have 3 options for S2. You may or may not have an S3 gallop present. So if the child is in CCF, you will have a gallop rhythm. Now what about murmurs? Now that's the problem. You have horrible diseases like TGA, you have the truncus, you have you have the TGA, you have the TAPVC which present very early to you, and in these diseases unfortunately the murmur may be absent, or at maximum you have a very short systolic murmur. You don't get anything more than that. Now as far as TOF goes, you will get an ejection systolic murmur and TOF-like condition. So if any of the others, so if you have a TGA with a PS, you can still have a TOF-like condition, which you have a pulmonary stenosis, and you may get an ejection systolic murmur. The one disorder that you could really identify with a murmur in a cyanotic heart disease is a truncus. So in a truncus, this huge chamber with this huge amount of blood traveling through this, you get a very loud murmur which is very difficult for you to characterize. It could be both. Now the problem with the truncus is none of the valves inside the pulmonary and the aortic systems are normal. So you have a lot of floppy valves, you have a lot of differently sounding valves. So in a truncus you can get lots of clicks, you can have systolic murmurs, you can have diastolic murmurs. So diastolic murmurs are because of regurgitation. So you can have all of these murmurs inside truncus. So truncus is basically one loud murmur with barely audible heart sounds because the murmur is so loud, and you can have lots of clicks heard. Another condition which is again the clue for it, especially in quizzes and stuff, is clicks, is Ebstein. So instead of murmurs, you end up hearing lots of clicks, right? So it's very difficult to diagnose a cyanotic heart disease based on a murmur. That's my point at the end of all of this. Usually depending on the state, so it's the features of CCF which would predominate. So you could have crepitations on examination of the respiratory system, you could have hepatomegaly on examination of the abdomen, the other system, so the rest of the GIT as well as the brain tend to be okay at this point of time. When we discuss TOF, we will discuss a little bit about how the brain can get affected, but as far as CCHD goes, as far as cyanotic heart disease goes, this is the extent of clinical features usually. Now, how are you going to make a diagnosis? So, clinically, you are going to make a diagnosis as increased or decreased pulmonary blood flow, right. So, increased pulmonary blood flow settings are going to present to you with features of recurrent respiratory infection. So, the way our shunt lesions presented in acyanotic heart disease. So, they could have recurrent respiratory infections, they could have CCF, they have growth failure. So, all of this can occur in decreased pulmonary blood flow, while in increased pulmonary blood flow they are marked by the absence of CCF, by the absence of recurrent respiratory infections, although they are prone for infections. They have an abnormal condition, they are prone for infections, but they also have growth failure, and they may have, especially in TOF, they could have cyanotic spells or in any TOF like conditions. So, a cyanotic heart disease which has a pulmonary stenosis as well. So, they could have cyanotic spells. They could also have features like squatting episodes. So, we will discuss this more in detail when we talk about TOF, right. So, these are essentially your features which help you make a clinical diagnosis, but basically at the end of your clinical examination, you are expected to come to a diagnosis of congenital cyanotic heart disease, increased or decreased pulmonary blood flow. So, if it's whichever it is, you are then going to talk about features of congestive cardiac failure, if there are any features of infective endocarditis. So, if none of these are there, you basically tell them what this is, and then they will ask you or your question paper will ask you what your possible diagnosis is. Like I said, it's usually, we just want you to enumerate which of them it could be. Based on the age, you could come to a conclusion. So, if you can make a conclusion of TOF or maybe PGA, that would be brilliant. So, this is how much you should know at least at your stage. So, what are the investigations? So, the investigations, I am not going into the general ones like a hemogram and things like that. We are just going to talk about the basic ones. So, that is a chest X-ray. Now, chest X-ray with cyanotic heart disease is beautiful because there are so many examples of abnormal things. So, one is the boot shaped heart, which we always see in TOF. So, you have the boot shaped heart, you have the, so this is TOF, you have the egg on side appearance, and that is in PGA. You have the figure of 8 or snowman appearance which happens in TAPVC. You have the box shaped heart which occurs in Ebstein. So, that is a lot of MCQs right there. So, you have the boot shaped heart which occurs in TOF, you have the egg on side appearance, so you have a sleeping egg appearance on TGA, you have a figure of 8 or a snowman appearance which you see in TAPVC, and you have a box shaped, a really large heart, so big hearted people which you see in Ebstein's anomaly. So, there are a lot of things which you can get on a chest X-ray. In addition, what we look for on the chest X-ray is whether they have pulmonary oligemia, in which case it is indicative of decreased pulmonary blood flow, or if they have pulmonary plethora. So, that is a lot of pulmonary blood flow which happens in an increased pulmonary blood flow setting. So, these are the things that we can diagnose on a chest X-ray. Next thing after the chest X-ray is the ECG. So the ECG, there are a lot of, so I'm not going to go into the details because I really don't think you need to know that much about it. So you can have axis abnormalities, especially seen in TAPVC and Ebstein. If you have an RVH, you have features of that. So you have poor progression of the R wave, which is seen in the ECG. If you have a truncus arteriosus, you have a really tall peaked P wave, because of the right atrial hypertrophy which happens in tricuspid atresia. I'm very sorry, not truncus arteriosus, in tricuspid atresia. So these are the cardinal features that we end up seeing in ECG in cyanotic heart disease. The clincher and the diagnosis, which unfortunately has made all of us forget the X-ray and the ECG, is the echocardiogram. So the diagnosis, the gold standard of diagnosis as far as we are concerned, is the echocardiogram. After the echocardiogram, before we decide to do surgery, many surgeons may end up doing something called a cardiac catheterization. So it basically gives them an idea of how blood is flowing inside the heart and how they need to repair the heart. Now what's the management? So the management of any cyanotic heart disease is surgery. Please remember that it is surgery. Now what surgery do we do? So before we do surgery, we will need to stabilize the child. So the first step always is stabilization. So our child has come to us on day 3 of life and has come to you in a really bad state, right? Is in congestive cardiac failure, has really bad tachypnea, has tachycardia, has a saturation which is just not picking up. So the first thing we need to decide is this a duct dependent lesion or not? Now sometimes we don't have the luxury of doing an echocardiogram and seeing if there is a patent ductus arteriosus. So if that's the state, what we do is we just assume that the duct is closing and we need to open up the duct. So what we do is we open the PDA. Now I know that most of you have visions of us now going into the heart and then opening up that PDA. It's nothing as dramatic as that. What do? We start them on a prostaglandin, that's PGE1 infusion. And the prostaglandins are responsible for keeping the ductus open in the presence of hypoxia in utero. So what we're doing is we're simulating that outside. We give them a prostaglandin infusion to open up the ductus. Now prostaglandins are very dangerous. They can cause hypotension, they can cause respiratory arrest. So when we start a prostaglandin infusion, you should have people who are competent to intubate the child and ventilate the child, because there's a high chance this child is going to go into a respiratory arrest. Now once we start a prostaglandin infusion, your next step is going to be to take up this child for surgery. Now it's just a matter of common sense, it's a cyanotic heart disease, this kid is saturating something like 60 to 80%. Obviously the earlier you do surgery, the better, and they are almost invariably surgical emergencies. Now what surgery do you do? It will depend on how much time you have, how much expertise you have. Now if you have a TGA, now whenever we describe TGA, we talk about intact ventricular septum or with a good septal defect, so usually a VSD, right? Now suppose you have a TGA with an intact ventricular septum, what we usually do to buy time is we do something called a balloon atrial septostomy, or it's called the Raschkein procedure, and this is again an MCQ for you guys. So a balloon atrial septostomy is a Raschkein procedure. What we do is we create a hole, or we make an ASD, so that there is some degree of mixing which can happen between this right and left side. So that's what we do with a balloon atrial septostomy. But once you do a balloon atrial septostomy, it's very important that you then take up the child for actual definitive surgery, and that's called an arterial switch operation. Okay, so basically you switch the two arteries. It sounds so simple, isn't it? Totally not. As expected, it's a cardiac surgery, so obviously it's not going to be simple, but you're going to do an arterial switch operation. Similarly, you have similar surgeries for almost everything. So TAPVC is another dire emergency which can happen, especially if one of these veins is obstructed. They are prone for obstruction. So a TAPVC, you basically re-implant the veins into the heart using various methods. I'm obviously not a cardiac surgeon, I'm not going to go into the details of that. Truncus usually is not an emergency at that point of time because you've got a well mixing lesion. TOF again is not an emergency at that point of time. So it's usually TAPVC, TGA, and very often tricuspid atresia, which become your important procedures to do then and there. Now even tricuspid atresia, if you've got a shunt, you can wait a little bit before you go on to do a definitive surgery. Now I need to mention at this point of time one particular disorder for which most centers in India do not have an operative procedure available, and I didn't mention this right at the beginning, and that is a scenario which is called a hypoplastic left heart syndrome. So I'm just going to talk about this very briefly here because this is one of those cyanotic heart diseases which can even present you on day 1 of life. So basically they have a poorly developed left side of the heart, and here again the duct is the thing which could sort of give them life for a very short period of time, because the pulmonary blood flow gets shunted to the left side of the heart. So the PDA works in the other direction, and the blood that's flowing from the left side of the heart can get pumped into the right side of the heart, from the right side of the heart can get pumped to the left side of the heart, so that the pulmonary artery can supply the aorta and sort of flow. So if I'm going to show you that in a flow diagram, so probably our other diagram is better. So what would happen here is none of this portion, so I'll just do that in black. So none of this portion is working, right? So you have nothing over there. So it could be a mitral stenosis, a mitral atresia, an aortic atresia, a hypoplastic left ventricle. So all of these come together and the left side of the heart is just not developed. So you just got the right side. So all the blood coming from the right side, what it does is it goes through the PDA into the aorta and it can supply the rest of the body. This is deeply deoxygenated blood. There is no oxygenated blood reaching anywhere, and this particular thing can then cause major problems. It's a very, very complicated surgery which we call the Norwood procedure, and then there are other procedures as well which have to happen. But this is one of those things for which we don't have much of a treatment as far as India is concerned. The final outcome, even in the best of settings, would be a cardiac transplantation. So this is one of those really bad diseases to have as far as a cyanotic heart disease goes. I didn't want to talk about this right at the beginning because it's just so depressing. It's really nothing much that we can do, especially in our part of the world. So hypoplastic left heart is one of those almost universally fatal conditions in our side of the planet. So what's the prognosis? Prognosis obviously depends on how you diagnose, when you operate. The sort of roadblock as far as many places are concerned is the diagnosis of congenital heart disease. So the prognosis has actually improved because of SpO2 screening at birth. So as I said, we basically look at right upper limb as well as right lower limb saturation, and we look for a difference between these two. So there should ideally be no difference, or maximum if there's a difference, there should be a difference of a few percent, 1 or 2%, should not be more than that. But if you have a right lower limb saturation which is less than 94% persistently, and a right upper limb saturation which may be normal or both are abnormal, it's a failed SpO2 screening, and that becomes an indication for you to look for congenital heart disease, right? Now Kerala is one of these states which has implemented this, has a program called Hridyam in place, and because of that children with CCHD are getting operated right, left and center as early as possible, and this has led to amazing outcomes. So I must say that this is probably something that the rest of the states in India would need to emulate and follow, but the prognosis always depends on how early you can get them into surgery, and this is the reason why these children are not a problem for the West, because they get operated very fast. So there it's just a question of how quickly they are operated, and you can have children with PGA going into the OT right at birth. So it's basically diagnosed in utero, so it's diagnosed in the antenatal period, and they're prepared for these babies as soon as they're born, and they go directly from the delivery room into the operating room, and they will at least have balloon septostomy or something done before they can go in for a definitive procedure. So that's how the system needs to work. So the prognosis of all CCHD will depend on how quickly you can diagnose them and operate them. Of course, the later it goes, your heart cannot adapt to the different pressures that it has to go through, and obviously the body is not adapted for surviving in this kind of hypoxia. So the ultimate thing, if we don't do something, is death. So it's important for you guys to know how to diagnose, when to diagnose, to see and recognize cyanosis. This is not a practical class, so I can't really take you into how to recognize that subtle cyanosis which we can see in children, but it's important for you to know that it could be subtle, and an SpO2 screening is absolutely necessary. So if you have a brand new niece or nephew, I think you would do no harm and you would not offend any egos if when they're born you go and ask the very intelligent question of, have we checked the saturation in the right upper limb and the lower limb? You could probably save a life. Thank you.
Docemy.